Hi, everybody. Thanks so much for joining us today. My name is Anna Miners. I'm with Canopy EAP, and I'm joined here by Dr. Amanda Herleman, which I will introduce more thoroughly in a few moments. I wanted to get through a few housekeeping items. First of all, we are screen sharing, so hopefully you all can see the screen and hear us okay. We're also recording this presentation, so if you have to hop off early or you want to revisit the information or share it with someone following the presentation, you're welcome to do that. We'll send out a recording after we conclude. There is a handout that you are welcome to download from the navigation pane that outlines the Canopy fertility health benefit in partnership with ORM. And we're going to allow some time for questions at the end of the presentation today. So if you have questions, you're welcome to type them in as they come to you. Know that you may have them answered throughout the content presentation, but if they're not answered, we will be going through them at the end of the presentation. The only people that can see the questions that you enter are us as the organizers. I realize this can be a sensitive topic sometimes to ask questions about. So as the organizers, we can see the questions, but they aren't, you know, available to the whole audience to see who's asking what. You're also welcome to use the chat function if there are questions that you prefer to enter that way. So the questions box or the chat function, either one works just fine. So that's kind of the housekeeping. Like I said, I'm Anna Miners. I am the VP of Customer Success at Canopy, and we're really happy to be partnered with ORM. You know, at Canopy, we really try to provide inclusive, holistic, extraordinary member experience, you know, top level service to our members, and ORM is very committed in that same level and providing inclusive, holistic, comprehensive, and great service care with great outcomes. Today, I wanted to just briefly highlight some of the benefits of the relationship with ORM that you have as a Canopy member. Those include access to a discounted fertility health check, which Dr. Herleman may be talking more about, a care credit when the relationship comes through Canopy to ORM, and also just a number of resources, you know, from obviously a reputable information source as you're growing your family and as you're on this journey of family building. Today we're going to be talking specifically about the Love is Family program that ORM provides, which is designed to support the LGBTQ plus community in the journey to growing families. So without further ado, I do want to introduce Dr. Herleman. So Dr. Herleman is a board certified reproductive and endocrinologist and infertility specialist. Dr. Herleman has been with ORM since 2013 and really has a reputation for being thoughtful and providing compassionate care. And we're so happy to have you as our expert resource here today, Dr. Herleman. Thank you. And I'm going to turn it over to you.
Excellent. Thank you for that kind introduction. I'm really happy to be here today. And I hope that I'm able to provide you with just some good information about tools and resources that you may need to help you grow your family, because that's what we're all about. So I've got quite a few slides to get through, and like was already stated, we'll have time for questions. I want to make sure that's the most important part, is that you get your questions answered. And I'm going to try to figure out how to not have too many technical difficulties as I move through this. So who is ORM? So we were founded in the late 1980s, and we are now one of the largest IVF clinics in the United States. We provide comprehensive fertility care. So really, our whole mission is to help people grow their families in the way that is the most meaningful for them. We have a state-of-the-art embryology laboratory for our in vitro fertilization procedures and to take care of your little embryos. We have a very robust in-house egg donor program, which I'll be talking through in more detail. And we have a very high volume program of donor egg IVF and gestational surrogacy. So using both donor egg and a surrogate, which is what most, one of the options available for gay men to be able to have children with a genetic link. We have an international presence. I'm not going to really focus on that because you're all local. And that's really who we are. So that's me. I've been in the Pacific Northwest for over 20 years, except for a 3-year hiatus in Vermont, where I did my fellowship in reproductive endocrinology. I love my job. I do believe it's the best job in the world. And my other favorite, well, I don't really see it as a job, but I'm a mom of 3 wonderful boys, 2 of whom just graduated from high school last week and are going off to college, and then 1 younger son as well, and lots of animals. We really cherish the work we do with the LGBTQ plus community. We have worked to help grow families throughout the world for decades now, and it's an integral and essential part of the care that we provide. We're a big team of physicians, of nurses, of embryologists, geneticists, psychologists, andrologists, all the ists, who really are brought together with one mission, which is to provide compassionate and personalized care while providing you also with your highest chance of success of having a healthy baby. We are a group of 6 physicians, and we have also 4 nurse practitioners who we work with. And so the nurse practitioners are really integral in helping us be able to do ultrasounds and intrauterine inseminations and with communicating with you as well. We have locations both in the Portland area and Seattle. So our headquarters, really, where we rose from was in Portland. And our primary office in Portland is in downtown. It's right by Providence Park. And then we have 2 satellite offices. So at the downtown location, that's where the embryology lab is. So for people who are doing in vitro fertilization, that's where egg collections are going to happen. That's where embryo transfers are going to happen. And it's where embryos are stored. We have 2 satellite offices in the Portland area, one by St. Vincent's Hospital, and the other one kind of in what's called the Tiger Triangle, which is where I-5 and 217 intersect. And in our satellite offices, unfortunately, our office near St. Vincent's has been closed since the start of the pandemic, and we haven't, just because of staffing issues, haven't been able to reopen that facility. But I'm sitting in our south side location right now. And this is, where we can provide ultrasounds, do intrauterine insemination, blood draws, all those, anything that doesn't require the use of the embryology lab. We have a full service clinic in Bellevue, Washington, outside of Seattle. So there's a full embryology lab there. So when we start talking about growing your family, there's lots of ways that we can do it, and it can kind of depend on really what tools you have available to you. Do you have eggs? Do you have a uterus? Do you have sperm? And the yes or no to that is really going to drive what it is you need to help grow your family. So for some people, that may just be a lack of sperm, and so we need to do intrauterine insemination. For others, it may be either not having eggs or not having a uterus. And so there we're looking at in vitro fertilization, egg donation, gestational surrogacy, and we also have an embryo donation program, which I'm happy to talk about in a little bit more detail. So with in vitro fertilization, it's kind of broken down into 3 options. So the premise of IVF is that the goal is to help eggs to mature, and then we remove the eggs and we create embryos in the laboratory. So we can either have the intended parent grow the eggs, have the eggs removed, embryos created, and then the embryo replaced to their own uterus. For same-sex female or lesbian couples, we can do what's called reciprocal IVF, which I think is particularly lovely, which is where one partner provides the eggs and the other partner carries the pregnancy once the embryos are created. For those that don't have eggs, we can do donor egg IVF. And so where the embryos go can either be into a person's own uterus, into their partner's uterus, or into a surrogate. So I'm going to start kind of simple and then work through, so starting with intrauterine insemination and then spending some time talking about IVF and then really focusing on donor egg IVF and gestational surrogacy. I didn't add a whole lot of slides about testing. Testing or kind of pre-cycle testing is a key part of what we do, but the testing really depends on the treatment that you're doing. And so it was hard to kind of make it more specific. So if you have questions at the end of this about, well, if I wanted to do this, what kind of testing would I be looking at? We can certainly dive into that. So some people just, are in need of sperm and need to use donor sperm. And there's 2 ways to be able to do that. You can either use what's previously been deemed anonymous donor sperm, which is through a sperm bank, a sperm donor bank. We are moving away from using the term anonymous, especially in light of the fact that there's so much genetic information available online anymore with resources like Ancestry.com. And so while the identity of the sperm donor is not typically provided to you, there's no way for us to guarantee genetic anonymity in the world that we live in anymore. So I often refer to this as non-disclosure, so like non-identity disclosure. We work with several different sperm banks. The sperm bank that we do work the most closely with is the Seattle Sperm Bank. We have a partnership with them. So when you register with the Seattle Sperm Bank, you get a financial benefit. I think you get shipping is covered, which shipping sperm can be quite expensive. Not everybody wants to use sperm through a sperm bank. And so we also are able to help facilitate using a known donor. This does require more steps. The known donor has to go through the same process that a donor through a sperm bank has to go through. It's regulated by the FDA. So there's screening, there's medical evaluations, psychological evaluations, and legal agreements that need to be in place before we can move forward with that process. When using donor sperm, what we need to do is what's called intrauterine insemination. And this is where, so what happens is that you select the sperm or you use a known donor and the sperm is frozen. So in either case, the sperm is going to be frozen. So we will thaw the sample and then we put this little tiny catheter into the uterus, and then we put the sperm at the top, and then the sperm swim out and they meet the egg out at the end of the fallopian tubes. There's 2 ways that we can do intrauterine insemination. One is a natural cycle. And this is where we're just using the natural menstrual cycle. And so we monitor for ovulation by using what's called an ovulation predictor kit, or an OPK. This is where you're testing your urine. And as you're getting ready to ovulate, so for a few days, you'll just get like nothing, nothing, nothing. And then one morning, you'll get a smiley face. And the smiley face means that you're going to ovulate the next day. So we would have you come into the clinic the next day for the insemination. Sometimes with a natural cycle, we will do ultrasound monitoring. We may use what's called a trigger shot, which is a small injection that's going to help trigger the release of the egg in a very predictable way. So then we can more accurately time when we do the insemination. The second approach is using a medication to help kind of boost the number of eggs that are growing. Or if somebody has irregular menstrual cycles, we can also use these medications to help regulate the menstrual cycle so that we can time things more appropriately. When we're doing ovulation injection with these medications, we do monitoring with ultrasound, and we use the trigger shot. And so with a natural cycle, you may not need monitoring or a trigger shot, but when you're using the medications, those are both part of the process. So the medications that we use, there's two. One is called Clomid and one is called letrozole. So, what happens, this whole process is really, coordinated events that are happening with communication between the ovary and the brain. And your brain is really the thing that's in charge. And so your brain makes this hormone called follicle stimulating hormone, FSH. FSH travels to your ovaries and it tells the eggs in the ovaries to mature. And as those eggs, the eggs live in these little sacs of fluid that are called follicles. So when we do an ultrasound and we look at the ovaries, you see these little black circles. I have some slides here where you'll see some ultrasound representation of follicles. And so as the eggs mature and these little follicles grow, they make estrogen, and estrogen is how the ovary talks to the brain. And so the brain gets that signal, and it's like, and in a normal cycle, it's like, oh, okay, the ovary is doing its job. I don't have to work as hard, and the brain is going to decrease FSH levels. And so that allows just one egg to grow and to be released. The medications that we use, Clomid and Femara, what they do is they interfere with how the brain senses estrogen, either by blocking a receptor or actually preventing the creation of estrogen. And so what happens is your brain says, okay, the ovary is not doing its job. And in response to that, it makes more follicle stimulating hormones. So you have a stronger stimulus to the ovary to help more eggs to be released. So instead of one, we're aiming for 2 or 3. And so if you can increase the number of eggs that are released, you're going to increase the probability that at least one of them is going to fertilize and implant. But you're also going to increase the potential that more than one of them could fertilize and implant. So there is an increased risk of multiples when we're using these medications, which is again one of the reasons why we do the ultrasound monitoring, to make sure that you're having the correct response. If the success rates with IUI, as all things in reproduction, are based on the age of the egg, because as women, as females, we are born with all of our eggs. We have one supply, and we work with that supply over the course of our lifetime until we run out. And what also starts to happen is that there are changes with the quality of the eggs. So as the eggs get older, more of them become associated with genetic abnormalities, and the genetic abnormalities make it harder to get pregnant and harder to stay pregnant. So typically on average, the chance of conceiving at 25 is going to be about 25%. At 35, it's about 15%. And at 40, it's about 5%. Generally, just one more thing about IUI before moving on to talking about in vitro fertilization. generally, because of those success rates, you're going to, potentially need to try more than once. And so typically we're going to try anything about 4 or 5 times. And so once you get out to about the, 4th or 5th attempt, we're no longer improving your chances of conceiving. And so at that point, we're going to regroup, talk about what we need to do differently, and kind of shift gears with what our treatment plan is. And generally, if we're not successful with intrauterine insemination, IVF is the most effective next step in treatment. So like I spoke about earlier, there are lots of ways that we can do IVF. We can do IVF with a person's own eggs, or we can do IVF with donor eggs to create the embryos. So once the embryos are created, they can be transferred either to the person's own uterus, to their partner's uterus, which is what we call reciprocal IVF, or to a surrogate. And with donor eggs, the same process and same options. So I'm going to kind of dive into the IVF process. And these are where I said there was going to be some slides with an ultrasound. So these are ultrasound images of an ovary. And this image on the left shows there are these little black circles. Each one of these is a follicle. So there's an egg inside each one of these. And the eggs in these follicles compete with one another over the course of the menstrual cycle to be the winner. So usually one wins, and then the rest of them die. And then in the next cycle, another group comes right behind it, and the same thing happens. And what the premise of IVF is that we want to take this whole group and we want to help them all to grow. And the way that you do that is by taking injections of the hormones that come from the brain, FSH and LH, that stimulate that process. The injections last for about 8 to 13 days. And we're watching you really closely over that period of time, watching how the follicles are growing, watching how the hormone levels are changing. And at a certain point, we can tell by the size of the follicles that the eggs are likely to be ready. And at that point, then you'll have, or whoever is undergoing stimulation will have the egg retrieval. So this is the procedure where we go in to remove the eggs. The person is asleep for this, and it's done under ultrasound guidance. So we use a vaginal ultrasound probe that has a little needle guide on it, and then a small needle goes into the ovary, and then the fluid from all those follicles is removed into little tubes, and then the embryologist looks at the fluid and finds the eggs. So this little circle, black and white ultrasound image, you can see coming in at 12 o'clock, there's this bright line. This is the needle going into the follicle, and then there's suction, and so all of this fluid is released. And a little egg, as it matures, before it's mature, it's like stuck to the side of the follicle, and then as it matures, it releases from that connection, and it's just floating in the fluid. And so we take the fluid out, and then we hand the fluid to the embryologist, and then the embryologist looks under the microscope, and then they find the eggs. So we aspirate all of those little follicles. We do one ovary and then the other. It takes about 20 or 30 minutes. It's very straightforward. And then we find these beautiful little eggs. And then the next step is that we need to fertilize the eggs. And there's 2 ways to do that. You can do what's called natural fertilization, and that's just where we're going to just dump the sperm on the eggs and see what happens. Or we can do what's called intracytoplasmic sperm injection, or ICSI, and that's where the embryologist will look at the sperm. They'll pick up the healthiest appearing sperm and then place it directly into the egg. So then we look the next day and we see how many of the eggs fertilize. It's usually about 70%. And then we watch these little embryos grow for 5 or 6 days. And so the cells are dividing each day. So on day 2, there's going to be 4 cells. And on day 3, there's about 8 cells. By day 5, there's about 100 to 150 different cells within the embryo, and the cells have started to specialize. So you have, here you can see at 9 o'clock, there's this kind of little clump of cells. These are actually the cells which are going to become the baby. And then there's this outer layer of cells. These are called trophectoderm cells. These are the cells which are going to become the placenta. So we have options about what we can do at this point. We can either just look at the embryos and say, okay, this is the best looking one. Let's put this into the uterus the embryo is going to go into, whether it's the person who had the egg retrieval, their partner, or a surrogate. Or we can learn more about the embryos by doing genetic testing of them. And what the genetic testing is looking at is the number of chromosomes that are in each of the individual embryos. So the chromosomes are the DNA. They're the instruction manual on how to make the baby. And so in order for the instruction manual to read right and for healthy development to happen, there has to be the correct number. There have to be 2 copies of every chromosome. And so what we also know, and what I alluded to earlier, was that as the eggs get older, more of them become associated with genetic abnormalities. And so this is a graph that shows age along the bottom, and the percentage of embryos that are chromosomally abnormal along the vertical axis. So, and what you can see here is that, you know, up until about the age of 34 or 35, it's relatively stable, and then this number starts to increase dramatically. And so this is the reason why it becomes harder to get pregnant. This is the reason why we have an age cutoff for people that are using donor eggs. So 32 is really the cutoff for donor eggs, because we want to ensure that we're going to be obtaining the healthiest eggs possible. And so the genetic testing is really going to allow us to determine which of the embryos has the highest potential to result in a healthy birth. And you can see the benefit of that when you look at this table that shows the green bars are embryos. This is implantation rate. So after embryos have been transferred, and whether or not genetic testing was performed. And so in the green line, genetic testing wasn't performed. And as you would expect, as age goes up, the chance of success goes down. Now, when you do genetic testing and you're transferring a genetically tested embryo, although there's a little bit of bounciness along this line, it's not significantly different from age group to age group. So the genetic testing really improves the chance of success per embryo by allowing us to identify those embryos that have the highest potential to result in a healthy birth. So I didn't really have a slide about embryo transfer. So if you're not doing genetic testing of the embryos, we can do what's called a fresh transfer. And that's just where we take the embryo and we put it into the uterus about 5 days after the egg retrieval. If the uterus is not the person who provided the eggs, those cycles are going to need to be synchronized, whether that's the patient, the partner, or it's a surrogate. Things would be synchronized so that we would do the embryo transfer 5 days after the egg retrieval. With genetic testing, or if you're using a surrogate and you haven't matched with the surrogate yet, the embryos are going to be frozen. And then there's a kind of uterine stimulation process that happens, and then one of those little embryos gets thawed, and then we transfer that to the uterus. So I want to focus a little bit on donor egg, IVF, and surrogacy, which is really what gay men need in order to be able to have a child with your own genetic contribution. And it's a process. And kind of the basic kind of roadmap that is followed is there's research and planning. So usually you're going to talk to different fertility clinics, you're going to talk to different surrogacy agencies, you're going to create your team, because it really does take a team. The fertility clinic is responsible for helping with the medical management of the egg donor, of the creation of the embryos, and then the medical management of the surrogate. The surrogate agency, if you're working with an agency, is really there to help navigate all of the logistic and legal pieces that are required for a safe surrogacy process. So the next step, after finding an egg donor, is creating the embryos. Oftentimes what we'll do when there are two male sperm providers who both want to provide their contribution, you undergo, the egg donor will have the eggs retrieved, and we split the eggs in half, and we fertilize half with one person's sperm and half with the others. So the embryos are then created, and oftentimes you haven't yet matched with the surrogate once the embryos are created, so the embryos are frozen, and then you match with the surrogate. The surrogate then comes to see me, and I do updated testing to make sure that everything looks good. And then all of the contractual pieces are put into place, and then the surrogate undergoes the embryo transfer, and then you have your baby. So we have, at ORM, we have our own in-house egg donor program. Our donors have been extensively screened, so they've undergone significant genetic screening, medical screening, psychologic screening. We want to make sure they're a really good fit for the program before they're invited to be in it. I think we take about 6% or so of the people who apply to be donors. We really appreciate our donors. We know them well. Just by the nature of, how frequently we get to see them. And so the program is set up in a non-disclosure way. So that's kind of the default, but some people want to know, they want to know the donor. So they may want to just talk to them once, they may want to meet them once, they may want to have an ongoing relationship. That's all going to be based upon what your desires are and what the donor is willing to do. And more, most donors are willing to be known. We generally recruit locally, so we recruit throughout the Pacific Northwest. This really helps to minimize travel costs associated with the donor's needs to be able to come to the clinic. Through our egg donor program currently, these are all what are called fresh cycles. So what that means is that you will select the donor will undergo the stimulation process, and then the eggs are retrieved, and then you receive everything that was obtained from that cycle. And on average, in our clinic, it's about 22 eggs. And then we create the embryos, and then through, and complete the process that we've already talked through. Alternatively, there are what are called egg banks. And in an egg bank, the donor has already undergone the stimulation, the eggs have been obtained, and they've been frozen. So they're not fertilized, they're just frozen eggs. And when you're using a frozen, you're going through an egg bank, you're going to get a certain number of eggs. You're not going to get 22. Usually in each cohort, it's between 6 to 8 eggs. And then those 6 to 8 eggs will be shipped to ORM, and then we would create embryos with those eggs. So there's pros and cons to each. Neither is right or wrong. With fresh eggs, you're usually going to have more embryos. You're going to know that the donor has had the most up-to-date screening, and there's a higher success rate, which is really associated with the higher yield of eggs. With frozen eggs, you're not going to have as many embryos because you're not going to have as many eggs, but it is lower cost, and typically there's no waiting because the eggs have already been frozen. So you don't have to select the donor, make sure that the donor is available to do the stimulation, go through the whole stimulation process. So it does help kind of speed things up. But for everything that is kind of a pro on one side, it's a con on the other. But like I said, they're all reasonable and good options, and we do both. So once the embryos, like I mentioned, once the embryos have been created, you will match with your surrogate. If you're working with an agency, that match is going to be made with the agency. You will have an initial match meeting, and if you decide to move forward with that surrogate and the surrogate wants to move forward with you, then we will complete the medical screening of the surrogate. We'll review their medical records. We'll complete the necessary medical exams that they need to be able to move forward. And then we're going to be responsible for their medical management, both through the embryo transfer process, and then we will manage the medical care through about 10 weeks of gestation, so almost to the end of the first trimester. And then at that point, that's when all of our patients kind of transition back to their OBGYNs. These are success rates with using donor egg and a gestational surrogate. There's a single embryo transfer and double embryo transfer. We're really moving away from double embryo transfers. The medical recommendation, and this is all just based on safety, is for a single embryo transfer. And the live birth rate is about 70% using donor egg and transfer to a surrogate, which is significantly higher than what it is for the national average. So just a little bit about our relationship with Canopy and what that provides to you. We have what's called a fertility awareness check. I'm going to talk through kind of both of those options. You will be provided a care credit of $300, which can go to be applied to ongoing treatment with us for attending. Unfortunately, it can't be used for the new patient visit because of some insurance issues, but for ongoing testing or treatment, it can be used for that. And then you also have access to additional resources through the Canopy portal. So the fertility, we have two different fertility awareness checks, one's for eggs and one's for sperm. And this is just providing kind of basic testing to you to look at what's called ovarian reserve, looking at the quality and the quantity of the eggs that you have within your ovaries. And this involves having blood work drawn, where we're looking at hormones that give us information both about the quality and the quantity of the eggs, and this is provided to you at a reduced cost. So I think it's $299, and you would call when you get your period, and then we get the blood work done within the next few days. And then you also have a pre-consultation, and then the results are provided to you, and the nurse practitioner will talk you through the results. And then for sperm, the fertility awareness check is really a semen analysis. The semen analysis is just going to help us to make sure that there's no significant issues with the quality or the quantity of the sperm. And again, this is provided to you at a reduced rate as well. That was a lot of information. I really appreciate your time, and I hope this was beneficial for you, but I really want to turn it over to you now to ask your questions and let me know how I can help.
Thank you so much, Dr. Hurleman. There is one question so far that has come in from someone asking just where to start. What should be the starting point? Do we get fertility health tested? Do we speak to someone to figure out a game plan? Like, what is the first step in all of this, and somebody deciding kind of like what to do?
I think the best thing to do is just schedule a new patient visit, and that's going to be, you know, an appointment where you get to sit down with your physician. All of our new patient visits right now are done virtually, and it'll give us the opportunity to talk through your history, and if you have a partner, your partner's history, and to talk about what testing may benefit you, what treatment options are available, and really just to provide you with all of the information that you need to make an informed choice about how you want to move forward.
Thank you for answering that. I had a question too. I don't know that it's come in here, but if you could speak briefly to options for folks that aren't in the Pacific Northwest. I know you focused on that, but with, you know, with people working remotely and in different locations now, and then, you know, just our members being all over the country and all over the world, are there, I know there's things that ORM can do to work with people virtually. I know you can ship genetic materials, and I know there's some things that have to be done, you know, in person, of course. So if you could speak just kind of high level or briefly about options for people that are not, you know, close or local to the Bellevue or the Portland offices.
Yeah, we take care of people from all over the world. So, but our only embryology labs are in Portland and Seattle. So we do have clinics in Israel and China, in England, but we take care of people from over 40 different countries and pretty much every state in the United States. So, you know, we are able to establish local relationships with providers to allow for monitoring. So there's a lot of monitoring that can happen that doesn't require being in Portland or in Seattle. And so that can be done locally, but then if somebody is, so for example, if someone is doing an IVF cycle and they're using their own eggs, they usually can start that stimulation process at home, have monitoring done for half of it, but then they would need to travel to Portland or Seattle and be here for about a week or a week and a half so that we can monitor their ovaries and then have the egg retrieval. Most people are able to go home the day after their egg retrieval. You know, if you're, you know, for people that are doing donor egg and gestational surrogacy, living internationally, one of the things that the pandemic really challenged us to figure out was, because we used to require people to come and provide the sperm sample for freezing. But then, you know, for international patients, once the borders were all closed, that we couldn't do that any longer. But now we've set up, we have international laboratories that will freeze the sperm, and then the sperm is shipped to us. And so for males who are doing donor egg and surrogacy that live internationally, often they don't have to come to the United States until they have to come meet their baby. But it really depends. There's, you know, it's kind of a fluid part of how we operate.
That's really helpful. Thank you for such a thorough answer to that. I think that was interesting to some of the folks in attendance. Let's see, what other questions do we have? I'm just taking a look. So it looks like there haven't been any other questions specifically entered. So for those in attendance, if you have a question, I would encourage you to do so now. We also chatted a link in the navigation bar that allows you to fill out some just basic general information to get connected with the scheduling team at ORM to kind of start that initial patient consult or or next steps on any of these pieces. So if you have any questions, we do welcome those. But also while folks are doing that, just reminding everyone that we're recording again, and following the webinar, we'll send an email that has the link so you can share it with others if you would like. The handout that's included in the navigation bar does outline the benefit that Dr. Hurleman was just talking about as well, with the care credit and the discounted fertility health check services. And let me just see here if any other questions have come in. It looks like no other questions, Dr. Hurleman. So I just want to thank you so much. You provided such a thorough overview. It was very, very helpful. And that may be a testament to no questions. Maybe folks' questions are answered just with the level of information that was provided. We really appreciate that. And your time in providing this, and just the partnership between ORM and Canopy. So thank you again for joining us today. Any final thoughts or anything from you?
Just thanks for organizing this. Thanks for letting me be a part of it. There's a lot to this as you're starting to navigate what the different options are. It can sometimes feel overwhelming. Just know we're here for you. This is what we do, and we look forward to helping, continuing partnering with Canopy and helping you on your journey.
We appreciate that. Thanks so much, Dr. Hurleman, and thank you everybody for attending. With that, we will go ahead and end the webinar for today, and we'll follow up, with everybody as I've outlined.
Great. Have a wonderful day.
Thanks, everyone.